pleasant morning to all of you. This is Dr. Sinta signing in here for Zoom webinar organized by GMOA and Society for Health Research and Innovation. Today, our first lecture is going to be on important clinical topic, catching it early, cancer detection in primary care. Kindly mute your microphone and turn off the camera during the presentation and use the chat box to clear your doubts at the end of this presentation. Now, it's my pleasure to introduce Dr. Nuradh Joseph, consultant oncologist currently attached to the teaching hospital, Batticlo. Thank you for joining us today, and the floor is yours.
Thank you for this opportunity to speak on early detection and early diagnosis of cancer. I wish to thank the GMOA, especially its president, Dr. Nuradh, Vice President, Dr. Shantika Pitakadwa, and Secretary, Dr. Senar Fernando, for organizing this, as well as the Society of Health Research and Innovation. So I will briefly take you through the burden of cancer in Sri Lanka, the importance of early diagnosis, and then move on to cancer screening and early detection. So it's clear from this data that cancer incidence is rising in Sri Lanka. It has gone up by about, the incidence itself has gone up, the crude incidence has gone up by more than 4 times from 1985 to 2015. Whether this is due to better diagnosis, better registry recording, or an actual incidence, we don't know, but definitely as far as the registry data is concerned, there is a significant rise in the cancer incidence in Sri Lanka. And this is age-specific ratio. You can see even if you consider 2005 to 2015, there is a significant increase in the incidence of cancer. If you look at age distribution, you can see that age is a risk factor for cancer. So that's something you need to bear in mind when you see a patient above 50 years. You can see there is a high risk of incidence of cancer. So these are the 5 common cancers among females in Sri Lanka: breast, thyroid, colorectal, cervix, and ovary. The cervical cancer incidence has remained static, while other cancers have increased over the years. And when it comes to males, it's head and neck cancers, lung, colorectal, and esophageal cancers. I must place on record my gratitude to Dr. Suraj Pereira of the Cancer Control Program and the head of the Strategic Information Unit of the Cancer Control Program for providing us this vital data through the cancer registry. So when you look at mortality, you can see that it's head and neck, lung, and hepatobiliary cancers, even though it's not a cancer with very much of a high incidence. It causes a significant mortality. So you can see what the lethal cancers are in this chart. When it comes to females, of course, because of the incidence, breast cancer still is the leading cause of cancer mortality. But again, you can see other cancers such as brain tumors, mainly glioblastoma, lung, and other head and neck cancers, and also hepatobiliary. It's, even though the incidence is less, the mortality is high in these cancers. So the importance of early diagnosis, you can see this is a comparison of data between Sri Lanka and the United Kingdom. You can see that in the United Kingdom, they diagnose early cancers of stage 1, nearly double our proportion. We have more than twice the number of patients presenting with metastatic disease. So it really shows that we need to improve our early diagnosis. We need to diagnose our cancers at an earlier stage. When it comes to lung cancer, again, although this is a cancer where even in the United Kingdom, nearly half present with metastatic disease, you can see that in our setting, we are not really doing a good job of detecting these tumors at an early stage. It's the same with esophageal cancer. Again, a tumor where it's difficult to diagnose it early, but still our rates are less than half of what is found in the United Kingdom. And commonest cancer, head and neck squamous cell cancer, again, we are way behind what we should be. So there is certainly an urgent need to diagnose cancers at an earlier stage than what we do currently. So in the this is data from the United Kingdom. Nearly 1/4 of all cancers in the United Kingdom is diagnosed in the acute and emergency department. In other words, patients present with a medical emergency and then they are diagnosed with cancer. And these patients have a very poor prognosis compared to other patients. So even in very developed settings, uh, the need for early diagnosis of cancer cannot be overemphasized. So why do we need to diagnose cancer early? Well, firstly, it will improve curability. We can increase the proportion of patients who get cured by cancer. And also, it would mean that we can, the treatment that we deliver to our patients can be less intense so that there is the morbidity of treatment is less. For example, if we diagnosed a breast cancer at an earlier stage, we can then preserve the breast or conserve the breast and just treat it with a white local excision and radiotherapy, and rather than having to do a mastectomy. Also, if the tumors are very early, then we can avoid chemotherapy in certain instances. And also, uh, the treatment of early cancer would be less costly too. So if we do have a very effective program to diagnose cancers early, that would lead to cost savings in the long term. And so this is data from a study done in Sri Lanka. We can see that even in localized cancers, stage 3 cancers do worse than stage 1 and 2 cancers. So the earlier you diagnose your cancer, the better the survival is. And also, when it comes to metastatic cancers, you can see that the prognosis is very poor and it is incurable. So outcomes are better with early diagnosis. So on your left is a patient who underwent mastectomy, and on your right is a patient who underwent breast conservation surgery. So you can easily see that in terms of morbidity, if you diagnose cancers early, and you can institute less morbid treatment, the outcomes are better for the patient as well, apart from improving curability. So what are the causes of late diagnosis? So sometimes in some diseases, in some cancers, you saw with the data from lung and esophageal cancers, even in the United Kingdom, nearly half of these patients have metastatic disease at presentation. So some cancers the symptoms present only after uh, the tumor has progressed to a significant stage. So that is bad disease biology, really. So, and apart from that, patients, particularly in our setting, will delay to seek treatment. Even though they have a breast lump, sometimes they wait for nearly 1 or 2 months before they show it to a doctor. And the other causes are delayed recognition. Patients do present with significant symptoms, but we may attribute it to some other causes, or we may not recognize these symptoms as needing further investigation with a view to excluding cancer. So delayed recognition of sinister symptoms is also a significant cause. And then after you recognize it, there are pathway delays. These patients have to undergo various investigations, scans, endoscopies, biopsies, and so on. So depending on, so if your the system is overloaded with a lot of other with due to heavy demand, then there'll be delays along the diagnostic pathway. You won't be able to get a scan date early. You won't be able to arrange an endoscopy early. So all of these levels affect would lead to a late diagnosis of cancer. And so what are the strategies you can use to help an early diagnosis? So if cancers present or at an advanced stage, when they present with symptoms, then we need to catch them when they're at an asymptomatic phase before the patient develops symptoms. So that's screening. Health education will motivate patients to seek medical advice when they do develop symptoms. And then once patients present, we need to early detection and referral by primary care providers will ensure that once after the patient presents to the health system or to a doctor, that the diagnostic pathway is initiated early. And then you need to also work on systemic causes. You need to improve resources for scans, maybe improve the pathway so that there is an easier way for the patient to uh, access services. So these are strategies which will improve early diagnosis. I'm going to focus on screening and early detection and referral by primary care providers. So what is screening? So screening means identification of a disease in a population of asymptomatic patients. So patients do not have symptoms. The disease is diagnosed at an earlier stage than if the patient's presented with symptoms, and therefore a treatment can be initiated early. So the objective is obviously to diagnose cancers at an early stage, ideally before invasion has taken place, but at least before the tumor has spread to other organs. And it will improve curability. And as I mentioned previously, early stage cancers require less morbid treatment. And it is a form of secondary prevention. We are not preventing the patient getting the cancer. We are only diagnosing it early before symptoms. So what screening versus early case detection? This is a bit of an academic distinction. Screening is mainly for asymptomatic patients, whereas early case detection means that you diagnose your cancers early in patients who do have symptoms. So the history of cancer screening began with George Papanicolaou, who described the Pap smear test for cervical cancer screening in 1941, and it is still, in principle, one of the commonly used screening tests for any cancer, actually. So obviously, in screening, we are dealing with asymptomatic patients, so we need to consider a number of factors before we initiate screening programs. So it's epidemiology. Is the tumor prevalent enough? Natural history. Do you have an effective screening test? And also cost effectiveness of your screening strategy. So the disease should have a relatively high prevalence. So for example, bowel cancers, we can see in males and females, it's the third commonest cancer. And the disease should also have, should lead to substantial mortality and morbidity. So something like thyroid cancer, which is very curable, it makes sense to screen for thyroid cancer, even though it's the second most commonest cancer among females. It's not a cancer which causes a lot of mortality. And it's important to have a detectable preclinical phase. In other words, we should be able to catch the patient when the patient has developed or has developed the cancer, but has not gone on to have any symptoms yet. So cervical cancer and bowel cancer are good examples. If you look at pancreatic cancer or esophageal cancer, for example, or even lung cancer, the detectable preclinical phase isn't that great. And prognosis should vary substantially with stage. So whether you diagnose it, if you diagnose it early, your cure rates should be high than if you diagnose it late. Your screening test should have high sensitivity because you should be able to pick patients who do actually have the disease, and also high specificity. You should be able to, if your screening test is negative, it should mean that the probability of the patient having cancer is very low. Because you are dealing with asymptomatic patients, if the test isn't sensitive enough, you will be falsely reassuring patients. And if it isn't, so if sensitivity and specificity are low, it would mean that more patients would undergo unnecessary investigations, as well as more patients will be falsely reassured. And it should be easy to administer. It is done in asymptomatic patients, so it should be a user-friendly test and should be cost-effective. And if it is positive, you need to confirm your diagnosis with a confirmatory test. So what are the problems with cancer screening? So even in breast cancer, which is one of the commonest cancers, which where screening programs are in place, studies have shown that some studies have shown that it doesn't actually reduce mortality if your if your if the stage at which patients anyway present are early. So for example, in Scandinavian countries, they have stopped mammographic screening because their patients anyway present very early. So that's one of the problems with cancer screening, whether it actually, you will be diagnosing lots of cancers, but whether it actually reduces mortality is questionable for many cancers. But as you would see later, there are cancers where it's well proven. So in epidemiological terms, there is what you call a lead time bias, meaning that you will be diagnosing a cancer early. So it would give rise to a false sense that your survival is prolonged because you've diagnosed it early along the natural history of the disease. Length time bias is where low grade or less aggressive tumors are preferentially diagnosed through screening, so that if you compare patients who are diagnosed through screening versus the non-screening patients, you would get the uh, false sense that screening does actually improve survival. Overdiagnosis bias is where you diagnose lots of unnecessary cancers. For example, in prostate cancer, we know that a lot of the early prostate cancers are indolent. So if you have a screening program, you would be diagnosing and treating patients unnecessarily. And selection bias is where patients who do actually go for screening are anyway well-motivated patients, and they are the ones who are less likely to have risk factors to develop cancer. So these are very good patients who do actually access screening services. So we see that with cervical cancer, for example, a lot of the high-risk patients do not actually get screened, and those who do undergo screening are the patients who are anyway at low risk of developing cervical cancer. So these are 5 tumors where internationally there's some form of screening, and so breast cancer is the commonest cancer among females, and it is also perhaps the cancer where screening is widely used internationally. So the health insurance plan study demonstrated a reduction in mortality by screening with mammography. This was, of course, a study done in the 70s, 60s, and 70s. So, which is why I said some of the Scandinavian countries have found that their cancers are anyway diagnosed at an early stage, and so they have stopped mammographic screening. But in our setting, you saw that our rates of stage 1 cancers are nearly half of that in more developed settings. So I think there is a very urgent and unmet need for screening for breast cancer in our country. So early tumors are smaller in size, they have a better prognosis, they're less likely to have metastasized, so it improves curability and you can initiate less morbid treatment. So you can screen through mammography, magnetic resonance mammography, as well as through self-breast examination and clinical breast examination. So mammography is low-dose X-rays to image the breast. It will detect a mass lesion. Architectural distortion is where there is no mass as such, but there's distortion in the breast architecture, and of course microcalcifications are all signs of that warrant further investigation. So the sensitivity increases with age because younger younger the patient, the more dense the breast is, and therefore it's difficult to identify malignant lesions. So if you're above 50, you have a reasonably good sensitivity with mammography, and it is quite specific. I mean, uh, it has a very good specificity. In other words, mammography can exclude most. If the mammogram is negative, then your likelihood of having breast cancer is very small, although not 100%. And screening frequency, so that is where there is some controversy. But the shorter the frequency, the more likely that you would get, you would be able to diagnose interval cases where between screening a cancer develops. Uh, we'll see what the recommendations are for screening with mammography. So what are the problems? Again, I mentioned one, it's at young ages, the breasts are dense. It is radiation. So it uses radiation. So when you use it for asymptomatic patients at a population level, you might increase the risk of radiation-induced cancers very slightly. I have to say that that probability is very, very small. It requires expert interpretation. So if you do have a screening program, you would need more radiologists and radiology teams. And the aim of screening is to diagnose asymptomatic patients. So these patients do not have any palpable lesions or clinically detectable lesions. So if you detect something on the mammogram, then confirmatory tests also require further image-guided procedures, because these abnormalities can only be seen in the mammogram. So you'd have to have biolocalization biopsies and so on. So that requires additional expertise as well. And sometimes you may detect a lot of, as I said, indolent conditions which do not really need any treatment. But once you've detected it in the mammogram, that would require follow-up as well. So is it really cost effective? As I said before, in Scandinavian countries, they found it's no longer cost effective, but in our city, it is certainly would prove to be cost effective if we can initiate a mammographic screening program. Magnetic resonance mammogram is where you diagnose it based on the fact that tumors have an abnormal uh, blood supply, and it is recommended for high-risk patients where mammographic screening may not be suitable. It is costly, and it has a very high false positive rate. It detects lots of lesions, which in the end turn out to be negative for cancers. So self-breast examination, it is very cheap, but of course your lump needs to be, the breast lump needs to be of sufficient, of at least 2 centimeters before a patient or a non-medical person can detect it. Therefore, early lesions are missed. It has not been shown to reduce mortality, but it is a very good public health measure. It encourages patients to be aware of their breasts and to present early if they do, in fact, develop breast lumps. Clinical breast examination is a breast examination performed by a doctor. This is currently a recommended screening tool, but again, so if you do have a mammographic screening program, you need to combine it with clinical breast examination, because it would detect an additional 5% of cancers which are negative on mammogram. But again, there is no definite evidence of benefit through randomized control trials haven't shown, because even for a clinician to detect it, breast lumps need to be of a reasonable size, and sometimes clinicians do miss these lumps. Even quite experienced clinicians may miss early breast tumors. So it's not something that is very proven to be effective, but that's what is recommended in our setting. So there are certain patients who are at high risk of developing breast cancer due to hereditary syndromes. If you've had a first degree relative with BRCA-associated breast cancer, or if you're a mutation carrier, or if you have two first degree relatives with breast cancer. So one first degree relative doesn't increase the risk substantially, but if you have got two, then that means you're at a familial, you may be having one of the familial syndromes. And these patients should commence screening 10 years before the age of onset, before their youngest relative, but not before 25 years. So what are the guidelines for screening mammography? The most aggressive strategy is recommended by the American Cancer Society. So that's annual mammogram if above 40 years till 75 years of age. In UK, it's every 3 years if you're above 50 years. And the United States Preventive Task Force, which is the governmental body, says it should be every 2 years for those between 50 and 75 years. So in Sri Lanka, clinical breast examination is recommended for all above 40 years, annual clinical breast examination. But mammogram, the recommendation is between 50 and 70 years, every 2 to 3 years. That's what the guideline says. So, but we do not have a screening mammography service. But if a patient requests, I think between 50 and 70 years, every 2 years is a reasonably good screening strategy. Moving on to cervical cancer, it is actually the prototype cancer where screening program, where screening would work. It has a long preclinical phase and a very prolonged clinical course where you go from uh, infection of human papilloma virus to pre-malignant lesions to early malignant lesions and then to advanced disease. So, and there are very effective uh, screening and diagnostic tests, and in its earlier stages, just a cone biopsy can be curative. So it is one of the best cancers to actually, if you're looking for a model cancer for screening, then it is cervical cancer. And this is what I mentioned, you go from after HPV invasion, you go to a pre-malignant phase, and then you go to the malignant phase. And so this is where secondary prevention strategies can be implemented. HPV vaccination is primary prevention. It will prevent the patient getting HPV infection, and therefore, in theory at least, cervical cancer can be eliminated if we have a very successful HPV vaccination program. So there are 3 tests. You can use cervical cytology. They're previously called Pap smear test. And you can also look for Hpv Dna detection, which is more sensitive. And then you can also use visual inspection using acetic acid or Lugol's iodine. So cervical cytology, the earlier Pap smear is now what we use is the liquid-based cytology. And the aim is to identify asymptomatic precancerous lesions or early cancers. It's very cheap, and I think previously it has been cost just 300 rupees per test, so it's very cheap. So DNA testing will detect the DNA of the causative virus of cervical cancer, HPV, and the high-risk subtypes. It is more robust in the sense that it is more sensitive than cervical cytology, but it is more expensive and needs so PCR testing for HPV DNA. It is reserved for women over 30 years because at young ages you may have the infection which but in about a majority of patients, the HPV virus gets eradicated. It's not routinely performed, although in certain districts they did some uh, feasibility studies of HPV DNA, which will be great if we can introduce this. This is the screening method in other countries. So visual inspection with acetic acid, where you can see clinically on speculum examination, you can detect the abnormal areas in the cervix and then take biopsies from there. For this, the squamo-columnar junction of the cervix should be visible. So in elderly, if you are postmenopausal, the squamo-columnar junction recedes into the endocervix. So it's suitable only for younger patients. So what is the current recommendation? If you're more than 35 years, you should undergo cervical cytology. And it's very important to note that this should be repeated every 5 years, even if the test is negative, because as I mentioned previously, age is a risk factor for cancer. So just because you have a negative cervical cytology test at 35 years, it doesn't mean that you're not going to get cervical cancer in the future. So if it is normal, you have to have a screening in 5 years. If you have a low-grade squamous intraepithelial lesion, then you need to repeat the test in 6 months. If the test is normal, then you get back to population screening. But if the repeat cytology is also still low-grade squamous intraepithelial lesion, then you need to go refer the patient for colposcopy. If it's high-grade intraepithelial lesion, then you need to go for colposcopy anyway. If it's an invasive carcinoma, then obviously you need to do an urgent gynecological referral. So this is a summarized sort of outcomes pathway. The detailed recommendations are available at this at the cervical cancer screening guideline, which I would show you how to access that. So colorectal cancer again meets the criteria for screening. It has a reasonably high incidence and a long detectable preclinical phase, and early cancers have better survival. So there are basically four main screening tests, all of which have been proved, but there's no comparative data on which test is more robust. Fecal toccer blood is is very cheap, and it is probably the most useful screening test. Compared to colonoscopy, there is no primary prevention. I'll show you how colonoscopy leads to primary prevention. And the modern fecal whole blood tests do not require any dietary restrictions. And in fact, there is stools DNA testing, which is more effective as well. So if your fecal occult blood test is positive, then the patient needs to undergo colonoscopy. Flexible sigmoidoscopy is also recommended by the American Cancer Society based on the principle that most cancers are left-sided and that it's sort of a compromise between colonoscopy and fecal occult blood testing. Colonoscopy is the ideal screening in terms of screening test in terms of cancer detection, but it is invasive. It requires full bowel preparation and sedation and so on. But it will allow primary prevention through removal of adenomatous polyps. So both sigmoidoscopy and colonoscopy could prevent cancers being developed by removing precancerous lesions. CT colonoscopy is an alternative if colonoscopy is not feasible. So risk stratification, there are 3 factors to consider: past history of colorectal cancer, adenomatous polyp, inflammatory bowel disease, and a family history. So if all 3 are negative, the risk is average. And for average risk patients, the UK guidelines recommend a fecal occult blood test every 2 years if you are between age 60 to 75 years. But the American Cancer Society recommends either fecal cord blood test annually, or a 5-yearly sigmoidoscopy or a colonoscopy every 10 years, if you're between 45 and 75 years. So we see this distinction between the Americans and the British. The Americans have a more aggressive screening strategy. But again, it means lots of patients have to undergo these investigations, some of which are quite invasive. If you have, if you're in a high risk group, there is one first degree relative diagnosed, or more than one second degree relative, then you should commence population screening at 40 years. If you have a first degree relative diagnosed at a younger age, or more than one first degree relative, then you need to have a more aggressive screening strategy, and that should be colonoscopy beginning at 40 years or 10 years younger than the age of diagnosis of the youngest relative. So in these high-risk patients, you need to have colonoscopy because you need to institute some form of primary prevention through removal of adenomatous polyps. So high-risk groups, these are the high-risk groups, and the same principle applies. You need to, if you've got familial adenomatous polyposis, you need to have screening at a very young age. Same with HNPCC. So lung cancer, it is one of the, perhaps the leading, the number one cause of cancer mortality worldwide. You can see that both in our setting and in the United Kingdom, most patients present with stage 3 and 4 disease, where survival is just 15%. But if you're able to diagnose it early, you can institute curative treatment with very high cure rates. So low-dose CT chest is what is was the screening modality, because chest X-rays were found to be ineffective, and the national lung screening trial conducted in the United States showed a reduction in mortality by 20%. So the United States Preventive Task Force recommends a low-dose CT annually if you're between 50 and 80 years with 20-year back history. So prostate cancer screening, PSA isn't very specific or sensitive. You detect lots of indolent cancers. It is probably the cancer where screening does all the negatives of cancer screening. So not recommended routinely. Yeah, so this is what I said, lots of low-grade cancers are detected, and lots of cancers that do not cause any problems are also diagnosed and treated. So if a patient requests PSA testing, then, and the patient is between 50 to 70 years, you can offer it after the full explanation of the uncertain benefit, toxicity of tests, and confirmatory tests, and also of toxicity of treatment. So early detection, moving on to early detection of symptomatic cases again. So the medical educationists tell us that doctors use two main approaches for clinical reasoning. One is the hypothetical deductive approach, and the other is pattern recognition. Now, the problem with pattern recognition, which is what where experienced clinicians, as you become more experienced, you start using pattern recognition rather than hypothetical deductive approach, which is what, when you're starting your career, you would go using the hypothetical deductive approach, where you look at causes. For example, if it's persistent cough, then you look for causes of persistent cough and then move to exclude them one by one. But pattern recognition is where you look for patterns, and with experience, you start recognizing certain patterns. But the problem in cancer diagnosis is that for individual symptoms, you would see that the likelihood of cancer is still very low. So if you use pattern recognition, you're going to miss a lot of cancers. So this is the approach where you use a hypothetical analytical process versus a pattern recognition process. So you would have heard of these classical triads, flank pain, hematuria, and a mass. It's just less than 10% of renal cancer patients would have that. So if you're going for patterns, painless progressive obstructive jaundice is, of course, carcinoma of the pancreas until proven otherwise, but more than half of the patients would be inoperable and incurable. So if you look at predictive values, rectal bleeding, just less than, just about 8% of patients would have, with rectal bleeding would have rectal cancer. So if you use pattern recognition and you try and attribute, try to work on experience and a model patient in your mind, you would be missing lots of cancers. So we'll go through a few cases very briefly. So this is a 54-year-old smoker with COPD who presented with a 3-week history of worsening cough, had clubbing and shortness of breath, presented to GPs who just treated symptomatically, presented to the casualty, again treated as an acute exacerbation. And when the patient developed significant chest pain is when imaging was done, and that revealed a lung cancer. So you can see persistent cough has a positive predictive value of just 5%, and that's why it wasn't considered. And however, clubbing is a sinister sign, but again, unresolving symptoms should have triggered an earlier diagnosis of, or an earlier should have flagged the patient for further investigation. So pattern recognition, COPD does not cause clubbing, and the hypothetical deductive approach would say that sinister symptoms warrants further investigation. So this patient should have been detected, whatever clinical reasoning method you used. And these are the nice guidelines for chest imaging. We will consider these later. I'll put you a list of symptoms for each cancers. We move on to a patient with flank pain and right-sided flank pain with no alteration of bowel habits. Everything was normal. Presented to surgical casualty. They suspected a urolithiasis. X-ray KUB ultrasound was done. It was normal, but there was anemia. But the patient was discharged with NSAIDs, and symptoms persisted. Now complaining of epigastric pain, and a routine repeat ultrasound scan was done. Again, it's normal. But there's further anemia, and iron studies showed iron deficiency anemia, and that's when endoscopies were performed, and a cecal adenocarcinoma was diagnosed. So again, if you have got persistent abdominal pain, your probability of having cancer is just 3%, but anemia should have triggered further investigations, and even abdominal pain itself, even though it's just 3%, should have warranted more investigations in a 60-year-old patient. So bowel cancer symptoms, we will go on. I will show you the list subsequently. So this is a heavy smoker and alcoholic presenting with sore throat. There was no hoarseness of voice, no difficulty in swallowing, and GPs saw these patients and prescribed, treated symptomatically, and then they developed left-sided EIA cervical lymphadenopathy, and that's when the ENT referral was done to detect a hypopharyngeal tumor. So persistent sore throat in a smoker, current or former previous smoker, is a sinister symptom, and EIA and cervical lymphadenopathy are late signs. So if you want to diagnose early, you should have, for the patient with persistent sore throat, it warrants further investigation and should be referred to the ENT unit. So this is a 56-year-old patient presents with dysuria frequency, dyspepsia, and abdominal discomfort. Again, appetite and everything else is normal. The patient prescribed omeprazole, urine full report is normal, symptoms persist, there's a bit of backache, the patient again undergoes x-rays, it's all normal. But now the patient develops frequent bowel movements. That's when she's referred for a colonoscopy. Again, it's normal, but an ultrasound scan is performed after colonoscopy is normal, and C1 to 5 is performed after colonoscopy is normal, and that comes high, as high, and the ultrasound scan reveals ovarian cancer. So again, symptoms are vague, so it's diagnosed at a late stage. A high index of suspicion is needed, and CA 1 to 5 and ultrasound scan should have been done earlier when this patient presented at the diagnosis, presented with dyspeptic symptoms. Yeah, I'll show you the list of each tumor sites. So these are the triggering symptoms, these are the symptoms which should trigger urgent investigations. Breast cancer, any skin changes, or anyone above 30 years who have a breast or axillary lump. If it's only nipple discharge, unilateral nipple discharge or retraction if, in a patient above 50 years, needs urgent referral. If it's age 30 or younger, it needs a routine referral. If it's colorectal cancer, anyone above 40 years with weight loss and abdominal pain needs investigation. Anyone above 50 years with rectal bleeding needs an urgent referral with a view to excluding cancer. If you're above 60 and you have any one of the following, that is change in bowel habits, weight loss, and iron deficiency anemia, that needs an urgent referral. Any patient with a rectal or abdominal mass needs investigation, and as well as a patient with an anal mass and ulceration. So when should you use the fecal alpha blood testing in as a primary care physician? If your patient is above 50 with unexplained abdominal pain or weight loss, you can use it. If it's above 60, you need to refer the patient for a colonoscopy. If the patient is less than 60 years with altered bowel habits or iron deficiency anemia, then you can use the fecal alpha blood testing. But if the patient is above 60 years, then needs a colonoscopy without fecal alpha blood testing because the probability of cancer is high. In patients above 60 years with non-iron deficiency anemia also, it's worthwhile excluding a GI bleed. So ovarian cancer, I mentioned previously, any patient with ascites and abdominal mass should be referred unless it's obviously a fibroid. You should perform a CA 125 if the patient is above 50 years and you have any one of these symptoms: dyspepsia, early satiety, pelvic pain, urinary frequency, unexplained weight loss, or change in bowel habits. If your CA 125 is more than 35, then you need an urgent ultrasound scan. If the ultrasound scan is abnormal, you obviously need to refer the patient. If it's less than 35, or if your ultrasound scan is normal, then you need to consider other causes. For example, if it's altered bowel habits, then you need to go down the bowel cancer pathway. It's always important to review the patient again and reassess if the symptoms persist. So endometrial cancer, postmenopausal bleeding, is carcinoma of the endometrium until and unless proven otherwise. If a postmenopausal patient has vaginal discharge for the first time with hematuria, sometimes patients have difficulty in distinguishing postmenopausal bleeding and hematuria, anemia or thrombocytosis, or if the patient is diabetic because of Lynch syndrome, you should consider endometrial cancer. Head and neck squamous cell cancers, again, I mentioned any smoker or anyone above 45 years, hoarseness of voice, throat pain, neck mass, should be referred to the ENT unit. Lung cancer, again, if the patient is above 40 years or a current or previous smoker, any one of these symptoms, you have to refer urgently for exclusion of lung cancer through imaging and plus or minus a bronchoscopy. So hemoptysis is persistent cough, recurrent chest infections, unexplained chest pain, clubbing, shortness of breath, and cervical lymphadenopathy. If it's upper GI cancers, then obviously urgent endoscopy if the patient has got dysphagia, or if the patient is above 55 years with weight loss, very sinister symptom, weight loss, and any one of the following: abdominal pain, nausea, vomiting, reflux, dyspepsia. You need to do a routine endoscopy for hematemesis, which is probably caused by varices and so on, but you need to exclude a malignancy as well. So it's a routine referral. But anyone with above 55 years without weight loss, but with upper abdominal symptoms, abdominal pain, nausea, vomiting, reflux, or dyspepsia, you need to do a routine referral for endoscopy. Hepatobiliary cancers, obviously obstructive jaundice, but as I said, most patients at this stage are incurable. And if you're above 60 years with weight loss and any one of these symptoms, apart from upper GI cancers, you need to also consider hepatobiliary and pancreatic cancers as well, which will be detected on imaging. Prostate cancer, again, all patients with above 55 years with lower urinary tract symptoms should have a DRE and a PSA. That's recommended by Sri Lankan guidelines as well. The PSA test should be done after 4 weeks of resolution of a urinary tract infection. If your DRE is suggestive of malignancy, then you need to, or if the PSA is elevated, you need to do an urgent urology referral. So bladder cancer, again, hematuria above 45 years, it's bladder cancer until proven otherwise. If you're above 60 years and it's microscopic hematuria, or if you're above 60 years and you have recurrent urinary tract infections, it warrants a urology referral. Any painless testicular mass is carcinoma of the testis until proven otherwise. But without a mass, there's persistent testicular symptoms, worthwhile doing a ultrasound scan as well. Any penile, also a mass, after exclusion of sexually transmitted diseases, you should proceed to exclude a penile cancer. So general symptoms of cancers: weight loss, very sinister symptom. You need to consider colorectal, stomach, esophageal, lung, pancreatic cancers, as well as renal and prostate cancers. Loss of appetite is in upper GI cancers and bowel cancers, mainly also pancreas and renal. Deep vein thrombosis, cancer induces a prothrombotic stage, so unexplained DVT, you should proceed to exclude breast, colorectal, lung, and pelvic tumors, because you can find an occult malignancy causing DVT. So this is a complex diagram just to show you how you need to work through each symptom. So in summary, early diagnosis improves curability of most cancers. Screening will improve outcomes in breast, colorectal, cervical, and lung cancer. And delayed recognition of sinister symptoms will lead to diagnostic and therapeutic delays. In patients with red flag symptoms, your probability of having even in patients with red flag symptoms, your probability of having a cancer is often less than 10%, but therefore you should not rely on your clinical experience so much. You need to follow the pathway and actively exclude the cancer in these patients. It does mean that you need to investigate more patients, but still it's worthwhile, because if you catch a cancer at an early stage, you can increase the probability of cure. So remember that diagnosis delayed is treatment delayed, and treatment delayed is treatment denied. Further reading, this is the National Guideline on Early Detection and Referral Pathway of Common Cancers, a very comprehensive document produced by the Cancer Control Program, freely available to download. I've given the link. I would strongly recommend that you go through this, as well as the NICE guidelines that gives a very practical and pragmatic guidelines to, and it has guidelines on symptoms based on each symptom. It's a very useful document to go through, as well as this BMJ article, which is based on the NICE guidelines. And thank you very much once again to the GMOA and Shri for organizing this, and I'm happy to take any questions if there are any. Thank you for listening.
Thank you, sir, for that very excellent presentation. Now it's time to enlighten few queries. Please write your questions in the chat box. Abbreviation. So we got one more question from a participant. How about genetic counseling on breast cancer?
Yeah. So again, so there are. Sorry. Yeah. So genetic counseling is important if you have if you have a strong family history, more than two first-degree relatives or one first-degree relative less than diagnosed at 40 years, then you need to refer these patients for BRCA testing. It is currently available only at the Faculty of Medicine of the University of Colombo. So it is important to screen patients for if you have a strong family history. That said, only about 10% of patients would still be positive for an identifiable mutation, but still it needs to be uh, considered in these patients. Yeah.
Thank you very much, sir, for that explanation. And
Okay.
one more query.
Yeah. Anything to add? Yeah. So well woman clinics, I think. So they are. I think the well woman clinics are doing an excellent job in detecting cervical cancer or doing pap smears at the age of 35 years. But so follow up pap smears. It's very important because our median age of diagnosis is about 50 to 55 years. So just because your pap smear is normal at 35 years doesn't mean you're going to not have cervical cancer. So follow-up pap smears is as important as your catching patients at 35 years, as well as uh, yeah, that's what the existing pathways. So the rest of it, screening, mammography, fecal occult blood testing, that's for that has to be the ministry should consider certainly in initiating um, these screening tests. So HPV DNA testing is more sensitive than cervical cytology. If it is available, that it would be ideal to if you can do that. And regarding MRI or mammogram, so if you're above, if you have standard risk, then I would just stick with mammogram. If you're between 50 and 70 years, biannual mammography is sufficient. If you have a strong family history and you're less than 40 years or even 40 to 50 years, that's when you need to consider MR mammography as a screening test.
So the final query from a participant, is it preferable to do tumor markers for cancer screening, especially with the family history, especially with bowel and pancreatic cancers?
So no, not for bowel and pancreatic cancers. The only place of tumor markers for screening is not recommended. Meaning in asymptomatic patients, only PSA testing. Again, it's not a test that's. It's a test which has a lot of problems if you're doing it in asymptomatic patients. So the place to do a tumor marker is for ovarian. If you're suspecting ovarian cancer in a patient above 50 years with abdominal symptoms, then you need to consider doing a CA125. Other than that, for screening, it's not a useful test. Any alternative for stools for occult blood tests? So you can do a sigmoidoscopy every 5 years or colonoscopy every 10 years. Again, in asymptomatic patients, that's a very difficult test to deliver, or at a population level. ESR is there's a question about ESR. ESR is a very non-specific test. It should trigger an investigation if it's very high, an investigation of multiple myeloma. But for solid malignancies, if your ESR is high, it usually becomes high at a very, very late stage. So as a screening test, it's probably it doesn't have any value actually.
That's all about the questions, sir. If there are no more queries, I would like to thank Dr. Nuradh Joseph for his excellent presentation on behalf of GMOA and Society for Health Research and Innovation. And we would like to present a token of appreciation to Dr. Nuradh Joseph. Thank you very much, sir, for joining us today. And thank you all for your participation.
Thank you very
Stay
much.
tuned. Stay tuned for the next lecture. We'll be starting at 11 a.m., which is on a very important topic during this pandemic, COVID, distance learning, and how to face challenges as parents. Please stay tuned. 11 o'clock, we'll be back for the next lecture. Thank you all for your participation.